So what I'm hoping to do this morning is give you some definitions so you can nod appropriately and understand what people are saying in a way that has more insight, and also give you some insights into where neurosurgery fits into this. What epilepsies are the ones that may be more relevant to your practices overall. Quote, is anyone familiar with this quote? Exactly. Very good. That's the point of the system. So I'm going to start with the traditional system, and as foreshadowing, I'll have to say that as of this month, there's an entirely new system, and that gentleman over there is partly responsible for that new system. And I'll end with that. However, I have no sense for how quickly...
I'll just make the comment that the classification system, which has been in place for over a couple decades, is an evolution. And I think that's the safest thing to say.
Like all of science.
Like all science.
But like all of science and culture, we tend to be very much traditionalists. And I have a very strong feeling that this system, which has been used since the early 80s, and some of them before that, is going to continue being used. And this is what people are going to be using in the corridors. So we're going through this, clarifying, and I think all these terms are familiar to you, but maybe in ways that are not as precise. I want to run through this and talk about the sense of this, and please feel free to interrupt me, and we'll go from there. We talk about seizures and epilepsy, and of course those are not synonymous terms. A seizure is an event, an episode, and of course a seizure disorder can be synonymous with epilepsy. And we divide seizures into two types. What are now called focal seizures, what were once called partial seizures. And these are seizures that start within one circumscribed region of one hemisphere by definition. And with greater insight, we realize that that circumscribed region can be quite vast. And it's not one that you can even circumscribe. It might be a network phenomenon. But it's traditionally recognized as being asymmetric and unilateral. And the manifestation of that focal seizure depends upon how far that seizure propagates. So we divide partial seizures into three types: simple partial, complex partial, and secondarily generalized. And the difference between simple partial and complex partial is straightforward. It's the difference between consciousness and lack of consciousness. And of course, that's not straightforward, because I personally don't know what consciousness is. And so the definition is predicated upon a distinction that we as individuals, as scientists, as philosophers can't use. But we still divide that in operational grounds based upon whether a person is cognizant of the episode, is able to recollect the episode, is able to interact normally during it. So what is a simple partial seizure? It's essentially hallucination, and it doesn't matter what the modality is. And here's where focal seizures are really quite intriguing, in that the manifestation of a focal seizure depends upon the localization, of course. So we use the focal seizures to identify what might be the source of the seizure, and thereby make an anatomic localization. Complex partial seizures vary in manifestation and can show quite a spectrum of impairment, although we just talk about impaired consciousness. So a complex partial seizure might be limited to a person being amnestic for what occurred during the seizure, and you wouldn't know that until the seizure's over. Or it could be as significant as a person who's quite clouded and non-interactive. So in a sense, you walk up to a patient having what looks to be a seizure, because the person is cognitively impaired and was normal moments before. It can be difficult to say whether this is complex partial or not until after the seizure is over, based upon introducing the patient afterwards. That's part of why the entire system is revamped, because that's not a reasonable approach to this. And there's relevance to it, because the difference between simple partial and complex partial is the difference between driving and not driving. It's the difference between being restricted to one's occupational activities and not. And we think about that as part of the disability of epilepsy. But we realize that there's no clear boundary in brain function or human activity between the partial impairment, I hate to use the word partial, the limited impairment of a simple partial seizure and the greater impairment of a complex partial seizure. So this is all nuanced. And sometimes we just talk about partial seizures when we can't make the distinction whether they're really simple partial or not. As an aside, the term aura, NORA is a type of simple partial seizure. NORA is a simple partial seizure that is experiential, or it's subjective. So a person who has deja vu, or has a visual hallucination, or has an olfactory hallucination is having a simple partial seizure. Simple partial seizures also can manifest as motor phenomena, simple partial motor seizures. So those two types are both considered simple partial seizures. So of course, partial seizure may secondarily generalize. And by generalizing, it means that, well, we're seeing that both hemispheres are involved. But the reality is that both hemispheres are already involved when it's a complex partial seizure, because you're not going to have clouding of consciousness, impairment, unless both hemispheres are abnormal at the time of the seizure. In the sense that we think conventional wisdom is that when a seizure becomes complex partial, both sides of the limbic system, bilateral limbic systems are involved. Generalization is more of a behavioral manifestation. It's more a question of whether the seizure becomes convulsive or generalized tonic-clonic. And of course, the person who gives a history of having generalized tonic-clonic seizures may have seizures that are focal and then propagate, or may have seizures that start generalized. That's the right-sided column. So seizures that start generalized are generalized seizures. Seizures that are generalized at onset. Seizures that start focally can also generalize. The distinction for this audience is that the focal seizures, of course, are surgically addressable. Generalized onset seizures are not surgically addressable through resection. But they might still be surgically addressable in other ways. Generalized onset seizures can be absence, where this is when you all of you remember from medical school, where there's a clouding of consciousness and impairment that's limited in its manifestation, might just be blinking, might be a little bit of staring. It can look a lot like a complex partial seizure. And here's another problem, in that a person who has seizures manifested by staring may have complex partial seizures, may have absence seizures, and you can't know unless you have an EEG. The behavioral manifestation overlaps considerably. Tonic-clonic, of course, but what's important for this audience is that not all generalized convulsive seizures are tonic-clonic. A person can have clonic tonic-clonic, you can have pure tonic, pure clonic, and there's relevance to this, because that distinction influences or pigeonholes us toward what type of epilepsy is causing. I haven't even talked about epilepsy yet. But the tonic-clonic refers to the progression, starting off with increased tone, going on to clonus, which are repetitive jerks. Which brings you to myoclonus. So myoclonus, of course, can be epileptic. Myoclonus most often is not epileptic. Myoclonus is defined as a jerk. We all have myoclonus when we fall asleep. Hypnic jerks or hiccups are myoclonus. The difference between myoclonus and clonic is, again, a blurred margin, but generally distinguished by whether it's a rhythmic, repetitive jerks, or an individual jerk, maybe even in a cluster of non-rhythmic. In other words, a person may have myoclonus at the onset of a generalized tonic-clonic seizure, and the myoclonus might be like that, non-rhythmic, intermittent, and it go on to a tonic-clonic seizure. So these are nuances in the history that are important because it does increase or decrease the likelihood of certain epilepsy syndromes. That's anything so far that anyone would like to have me clarify, talk more about? So, epilepsy is the diagnosis, epilepsy is the disorder, the seizure is just a manifestation, and we know that most people who have seizures don't have epilepsy. The likelihood of having a seizure in one's lifetime is 10%, the likelihood of having epilepsy in one's lifetime is 3%. So most seizures are not related to epilepsy, most seizures are triggered by circumstance or ingestions or physiologic stressors, and the diagnosis of epilepsy is dependent upon having an intrinsic risk for seizures, which is most often manifested by having recurrent unprovoked seizures, but often in the context of other diagnostic tests, although not necessarily. The epilepsy syndromes classically are divided in the same way, divided between focal and generalized. And this goes along with the seizure type. And classically it's divided into idiopathic and symptomatic. And here idiopathic and symptomatic are being used in the way it's used outside the boundaries of the United States. Idiopathic has two definitions in the world, one for the United States, one for everyone else. Idiopathic in the United States means cryptogenic, right? Unknown cause. Idiopathic outside the United States means a disease unto itself, which is much more in line with the etymology. Idio, self, pathos, disease, right? Cryptogenic does mean hidden cause, so I have to say that we have distorted the definition of idiopathic, and the way it's used for epilepsy is based upon the international definition, because these are international definitions. So idiopathic epilepsies are defined as epilepsies in which the seizures are the only manifestation. The person is otherwise completely normal. And symptomatic epilepsy is one where the epilepsy is caused by something else that's causing another problem. So, to bring it back home to this audience, mesial temporal lobe epilepsy, the epilepsy due to hippocampal sclerosis, is a symptomatic focal epilepsy. It's an epilepsy due to sclerosis of the hippocampus, and that produces something else that causes memory disturbance, memory dysfunction, right? Whereas one can have a focal epilepsy is idiopathic if that epilepsy is due to only a rhythm abnormality. There's no other behavioral abnormality, cognitive testing is normal, and the person goes through a normal development. These epilepsies, of course, are not surgically addressable, and in fact typically respond very well to medications, and the general wisdom is that when epilepsies that are due to a non-structural cause, they're non-symptomatic, or they are idiopathic, in other words, medications typically work much better for seizure control. It's the symptomatic epilepsies that are more likely to be refractory to drug treatment. Now, what I've just said is completely wrong, because we realize now there's no such thing really as an idiopathic epilepsy. But if you look hard, you'll find that there's something else wrong with the individuals besides the seizures. It's just that prior investigations going back decades missed it. And that idiopathic epilepsy is a childhood absence epilepsy, where you're all educated to the fact that these are normal children except for the staring spells, and they grow out of it. In fact, have developmental abnormalities. They have much higher rates of problems with cognition. And it may be that the seizures themselves are interrupting awareness. It's unclear. Juvenile myoclonic epilepsy is another idiopathic epilepsy. This is one that develops in adolescence. It's one that has myoclonus, also has generalized tonic-clonic seizures. One sees considerable numbers of bifrontal bursts of abnormal activity. And it was thought again to be idiopathic because structurally the brain is normal, cognitively patients are normal, but in reality they're not normal overall. And it was missed because when we do cognitive testing, what are we looking at? We're looking at IQ, we're looking at memory, we're looking at visual spatial skills. Cognitive testing underestimates or underappreciates frontal function, doesn't it? Most cognitive testing doesn't look at inhibition, doesn't look at social cues. And the abnormality of juvenile myoclonic epilepsy was thought to be just an increased manifestation of adolescent behavior. Because at the onset in adolescence, these were just teenagers who were acting like teenagers. But in reality, they are a little bit outside of that. And maybe as an example, to draw the point home, is a patient I saw 2 weeks ago. It's a profound story of a medical student here, someone who ran from me originally, who was in his last year of medical school, age 21. You can do the math. Who, in his last year, started developing myoclonus and sort of ignored it as any good medical student would, just continue with rotations. In fact, myoclonus started occurring particularly during surgical rotations when he was sleep deprived. I noticed that he never had myoclonus other than during surgical rotations. This progressed over the year, that last year, to where he started having it more often. And it wasn't until he had a big jerk of myoclonus in front of his brother and spilled food all over himself that his brother insisted he go see a doctor for this. And his EEG showed considerable numbers, very, very frequent bursts of bifrontal spike and wave. And he just started treatment. However, over that same year, he stopped doing all his work. He sort of blew off his assignments. And this is a guy, of course, who was very studious and very driven for the first 21 years of his life, and then suddenly, with the development of this, for reasons that he couldn't explain to me, he still did well on tests. He scored high honors on the written exams, but when he had assignments to complete, he never got to them. It's curious, is this idiopathic or is this, another manifestation? The symptomatic generalized epilepsies include what is Lennox-Gastaut. And you think about symptomatic generalized, what does that mean? It means that the brain is structurally abnormal in a diffuse way, and what does that do for cognition? It produces mental retardation. The seizure types that correspond to symptomatic generalized epilepsies are generalized seizures, but they have different types with it. So this is the classic division based upon two axes, whether the epilepsy is idiopathic or symptomatic, and whether the seizures are focal or generalized. And you can think about taking all the different epilepsy syndromes, particular diseases, and fitting them into one of these four categories for the most part, except for epileptic spasms or infantile spasms, which produces a new challenge to us in terms of classification. Unclear as to what the real nature of it is. You'll see the EEGs here, and the point is that after the system was created, there was greater recognition that we should be talking about epilepsy conditions specifically, syndromes. And you see here examples of four syndromes as examples. That's really what we want to talk about when we talk about classification. We want to talk about particular diseases, don't we? Because when we reach a point of a disease, that's the point we all strive for in clinical medicine, which is to characterize the patient with a condition that we can know what is the prognosis if you don't treat, what treatments alter that prognosis, and what else do we do? That's all a doctor does, right? And then offers that treatment. Is there anything else we offer besides perform. And so if that's the purpose, then getting a system which allows for more specific diagnosis is the real goal, not just moving around these characterizations. So I'm going to use some examples from EEG just to illustrate this division. And the division comes out of EEG, really. This classification system predates MRI and is based upon behavioral observation in EEG. And EEG goes back to, of course, the 1940s for epilepsy. And much of the work that's been done for classification was with EEG. And I think it's with the MRI and maybe more sophisticated cognitive testing that we're revisiting all this classification. So just to remind everyone, even numbers are the right side of the head, odd numbers are the left side of the head. The greater the number usually represents a greater distance from the sagittal midline. So it's quite obvious on EEG when there's a focal abnormality, because it's going to hit the focal spike, and here's the focal spike coming on this EEG, lasting about 200 milliseconds, which is the typical duration. So seeing a focal spike increases the likelihood that this is a focal epilepsy. And not seeing one doesn't mean anything, because the EEGs, of course, are a sample in time, and 10% of people with epilepsy will have normal EEGs no matter how many EEGs you do instrumentally. It's the limit of the test in terms of sensitivity. So the early clinicians noticed this and compared it to this. And here we see what was called a generalized discharge. And you see bilaterally, so both sides, this is orientation of the EEG. It's weak, isn't it? It's the right side versus the left side. These are chains going across the lateral aspect of the head. This chain going across the top. You see this versus spiking wave. And again, for terminology, can anyone see this green dot? No. I can't. It's exactly. All right. So you look at the top line, and you see the very narrow burst. That's a very high amplitude spike. And then you see this alternation of a short discharge and a long discharge. That's a spike wave. And that's the hallmark of an epileptic discharge. But in many ways, it is more a sign of depolarization than a correction for that. The slow wave, in fact, may be a normal response to the spike, which is the abnormality. It's the thought physiologically. But the repetition of a spiking wave and a spiking wave occurs with generalized epilepsies more than focal epilepsies, although you might see a spike wave as a focal. Another important point is not all spike waves are abnormal. That's just the way it goes. But you notice that it starts bilaterally and starts suddenly bilaterally. This is why the concept was that this is a generalized onset. Then it ends bilaterally, then suddenly everywhere. Again, suggestive of being generalized. The concept was, and still is somewhat, that generalized discharges occur because of a rhythm abnormality between neocortex and the thalamus. That EEG in general is generated by those connections in both areas of gray matter, superficial and deep, influence rhythms that are present, and that the communication is abnormal. That's very much a hand-waving explanation. Only in the past few years has been recognized that, in fact, this may still have a neocortical source, and it's due to thalamic processing of a neocortical abnormality, and it just very fast propagation. What I'm saying here is that that boundary between focal and generalized is beginning to get blurred as well. It's still useful as a distinction. Here's another example of that. So what's a focal seizure compared to a generalized seizure? Because a generalized seizure is what I showed you just now, depending upon the duration. A generalized epilepsy may have a short burst between seizures, and then a longer burst of the same thing at the time of the seizure, where the burst might be, instead of spiking wave, it might be low voltage fast that builds up, but it's going to build up in the same way. A focal seizure has much more evolution, and the evolution that we see of the discharge over time corresponds to the evolution of the behavioral manifestation, the semiology, behavior of the seizure, where the beginning it starts focally, and here it's starting at T2, which is an anterior temporal electrode. See the battery replenished. And spreads out. You notice in the middle of the page, there's a rhythm that emerges from this low amplitude background. This is an obvious example of this, but of course it's not always so clear. And as it spreads out, you start seeing it emerging from electrodes that are neighboring to it on the scalp, but of course not neighboring on the page. And that propagation corresponds to the evolution of the seizure behaviorally, which might start as being a sensation, in this case maybe deja vu, and then progress to an impairment, and eventually might progress to a convulsion. Here, spreading these are 10-second pages. As the epileptic rhythm spreads, it's entraining surrounding tissue, which is normal. This is the surgical mission, is to identify which tissue is the abnormal tissue that, when removed, would be a successful treatment, compared to tissue that surrounds it that may allow the seizure to eclipse the function that's present there, subjugate that neighboring tissue to the function of the seizure instead of the function that it's purposed for. And as this neighboring tissue becomes part of the rhythm, there's impairment. That's the functional disorder of epilepsy. And I want to point out in comparison something that you see either in the ICU or well, it's always in the ICU for one of the sort of causes, and that's burst depression, which can have features of an epileptic discharge in terms of spikes and slow waves, but differs in that there's this simplistic rhythm that we see here is not present. That's one way to think about seizures, and I'm not sure if any of you have heard this analogy before, but I think it's a useful one that I use with medical students, frankly, but I'll use it here also. Because the idea of a seizure can be quite mysterious if you start thinking about it beyond, just some kind of alteration. Why should this be an alteration? And a simplistic analogy is that it uses the heart. And the heart, of course, is rather a simplistic thing. The heart does one thing. It pumps blood and it does that in one direction. End of story, right? There's nothing more to the heart. And in order to do that, of course, it has to be synchronized. And that synchronization is evident in EKG by this very simple discharge, which you see over and over again. Nothing more to it. What does the brain do? I don't know what the brain does. I mean, the brain does a lot. The brain does a lot simultaneously, and then integrates all that into one whole concept, which we then experience as ourselves. And in doing that, the activity electrographically of the brain is much more complicated. But a seizure one can think of as being a normal sinus rhythm of the brain. That when you start seeing a simple rhythm that eclipses that apparent disorganization, obviously it's not truly disorganized, because if it was, then we wouldn't be having this whole vision of the world. That makes sense. But as it eclipses that other activity into one rhythm, the normal activity that's supposed to be present is absent. So when thinking about when looking for a seizure on EEG, one should be looking for a simplification, or one frequency, one form coming out of what is prior appeared to be more chaotic. And that's abnormal. So you can see bursts and burst depression where there's several runs in a row, and it comes and goes. And there's no evolution, there's no simplified rhythm, which distinguishes it from a seizure. The other pattern that is controversial, and maybe relevant to epilepsy, are plaids, which all of you have come across also in the ICU. And plaids have the same form as an epileptic discharge. They have the same spike and wave feature, which is triphasic in its form. It has three phases. It goes down, it goes up, it goes down again, three phases. And plaids pathologically are associated with subacute neocortical injury. It doesn't matter what the injury is, although infection and infarction are the two most common, but that's probably related to those being more common in general. And plaids are these individual discharges, but occurring with regularity. You can see across the page, point here. This recurrent discharge, but there's no evolution. It's just the same thing over and over again. And the fact that it's occurring with regularity is different from the epileptic discharge I showed you before, which occurs randomly. The history also suggests that it's this injury, but the lack of evolution points away from it being a seizure. Now, it's controversial because the circumstances that can cause plaids also can cause seizures. And individuals who have plaids on long-term EEG may also have seizures. And plaids may be associated with functional imaging changes suggestive of increased metabolism, which might mean greater stress to that tissue, and salvaging it might be relevant. So some people will treat plaids, some people will not. And there's, again, a gray area between when is something become a seizure, when not. no conventional wisdom as to where that boundary is. So I'm going to talk about where we are now. So this month, the new classification system was published in the International Union Against Epilepsy. And the point of the system is to simplify and to make the system more biologic and to get rid of some terminology that doesn't help, but maybe actually confuses. So when you're in an elevator thinking about the prior classification system, you can maybe think about this and think about where what things maybe worth keeping, what things not. So what continues in terminology is focal seizures. We still talk about focal seizures. We still talk about generalized seizures, for that matter. We still talk about semiology or the ictal behavior, manifestation of certain descriptions such as impairment of motor function, impairment of visual hallucination, all the descriptions of things people can have as seizures. And then what remains with us are the syndromes. These well-characterized conditions such as mesotemporal lobe epilepsy, benign rolandic epilepsy, juvenile myoclonic epilepsy, these actual entities. What's been eliminated is the term idiopathic, because we realize that there are changes even with idiopathic epilepsy, so the term has ceased to mean anything, and there's confusion for now decades between the Americans and the Europeans as to what it meant. Also eliminated symptomatic, because if you look hard enough, you're going to find a cause, and that was also a lack of clarity. Symptomatic originally was meant to indicate some sort of structural change to the brain, either focal or diffuse. But what's the point of that? It doesn't really move us forward in terms of understanding the epilepsy. Cryptogenic was eliminated also because cryptogenic was used as a condition that was considered to be symptomatic, but the MRI was negative. So if you have somebody with focal seizures in onset in adulthood, likely that dude doesn't have a structural change to the brain. You don't see an MRI because it's cryptogenic. And the idea was, well, why base classification category upon assumptions? That doesn't make sense scientifically. Term benign, there have been certain benign epilepsies eliminated, with the recognition that even the benign epilepsies have disability associated with them. So what makes them so benign? Benign originally meant epilepsies that, these are particular syndromes that were generally self-limited. Kids grew out of them, and there was a cognitive impairment with them. But kids vary. So why promise something you can't come through by telling the parents, oh, it's benign? Else benign might be different things to different people. The distinction between simple partial and complex partial, gone, for the reasons I've already suggested. We don't know what consciousness is, but once we figure out what consciousness is, maybe we'll come back. And I did, of course, I'm not seeing any great movement toward scientific definition of consciousness. Partial has been eliminated simply because it's synonymous with focal. Why have two words for the same thing? Focal sounds good, it's fine. And there was a term a few years called localization related, which also is eliminated just because it means the same thing, and why use two words and many syllables when one word focal is used. And then for the epilepsies. The epilepsies are no longer divided into focal and generalized. Only because, why? You have particular syndromes like juvenile myoclonic epilepsy, temporal lobe epilepsy, the ones I defined. Why add this other structure to it when you can really when the real point is going toward the particular type of epilepsy? That particular type is what's relevant to you, because it will determine whether this is surgically addressable. And I said before, there's the focal epilepsies that may be surgically addressable through resection. But some of the generalized epilepsies also addressable. We already know that Lennox-Gastaut syndrome responds to vagus nerve stimulation, and of course a surgically implanted device. And although deep brain stimulation for epilepsy so far has only dealt with focal epilepsies, there's evidence that implantation in other locations, particularly central medial nucleus of thalamus, may decrease seizure frequency for generalized seizures, generalized onset seizures. So that type of classification is going to be very relevant toward deciding whether there's an operative indication here. New words, genetic. Genetic epilepsies now exist. Maybe that's because we now have genes identified, and the question about genetic versus idiopathic became blurred. Certain syndromes have more than one gene identified, and whether it's genetic or not has nothing to do with whether there's cognitive impairment or not. It's just a matter of the cause. Along with that, structural metabolic, because some are clearly due to structural abnormality, whether it's infarction or malformation of cortical development, it's unclear, or not, it's not relevant, it's still structural. And this in some ways refers back to the old term symptomatic, but more specifically. And we now use the word unknown instead of cryptogenic. That's maybe a simpler word. And the unknown would have to do with etiology. So the new regime really has to do with including more specific terms for etiology. Then the new system also eliminates a layer of classification in terms of focal or generalized, dealing more with just the seizure type, whether it's focal or generalized manifestation, and what the underlying epilepsy syndrome is. So I don't know how quickly this will be adopted. It's right now only available, I think, on EPUB. But I think this is where we probably are going to go, because it is simpler than the other.
This is part of WHO classification, because in the past they referred to WHO. Some classification were international classification. Is it going to be all over, or just for US or European don't accept it?
No, this is the International League Against Epilepsy. So this is the umbrella organization that includes the American Epilepsy Society and each of the national epilepsy societies. So this is the final word within epilepsy for classification. I'm not aware of the WHO with the ICD using their system, although the ICD system sometimes falls behind, so I don't know when the ICD might change. But as far as academic epilepsy, this will gradually be adopted, although I'm sure it's going to be a generational progression. And as Gary said, this is the point of evolution, because these changes are based upon science leading the classification as well as it should. And science continues to move forward.
Can you give us an idea of some of the fundamental mechanisms that are, let's say, going on in genetic, metabolic, are these transport mechanism deficiencies that are genetically based? Are they astrocytic changes that are causing it? Can you give us some clue as to what the thinking is?
The genes for epilepsy have fallen into two groups. There are some genes identified which cause structural changes like metabolic, and these are really symptomatic epilepsy, where there's something else globally wrong. It's like Lafore body disease. These are conditions that are neurodegenerative that have seizures with them. So they're not relevant. But for the epilepsies in particular, they have transient channelopathies. So we've identified mutations in the sodium channel, acetylcholine receptor, GABA receptor, calcium channel. That's it. But that's the common theme. And what's interesting is that for one electroclinical syndrome such as JME, there are now 4 different receptors that have been found to be mutated in different families with the same condition, suggesting that the genetic disease does not perfectly mirror the electroclinical syndrome. And so maybe the syndrome is a final pathway for a physiologic aberration that can go different ways. And of course, there probably are polygenetic. There's some evidence that for what were considered the idiopathic generalized epilepsies, this family that included juvenile myoclonic epilepsy, childhood absence epilepsy, GTCs upon awakening, that the genetics were such that there's one set of genes that influence whether the person would have that disease, and another set of genes that influence the manifestation of it, whether the person has myoclonus or not, or the person has absence or not. So the genetics in some ways, like genetics in general, get more confusing or more complicated as we go forward. Separate from that, maybe to address your question, is that idea of mechanism. And where the field is heading is the idea of networks. And skipping over the step as to why the network might be abnormal, which would, of course, be a genetic reason for the most part for almost all of these, and thinking about connectivity in the brain, functional and structural. And that, as evident through functional imaging, that's Verizon, the strongest technique for this, has helped blur the distinction between generalized and focal. And in fact, the new definitions for focal include the idea that there's a network that's not just discrete to one location, but a larger network that's involved. The same is true for the generalized. And I think the distinction might actually be what the network is. Some networks are more bilaterally represented, and some networks are more unilaterally represented. So it's all part of the same thing. And that's a lumper. The slur point would be that, well, there are differences, and those differences will steer individual therapies.
One follow-up. 20 years from now, how are we going to be treating this disease?
I think, let me say I hope. put it that way. I hope, and I'm glad that certain individuals are not in this room right now, I hope resective surgery is not being done very commonly. But I expect also using implanted devices that more refined stimulation techniques and implanted stimulators maybe even a greater role. And there's already evidence for that building up, on the epilepsy. I think the other part will be some medications that may alter the progression of epilepsy through neuroprotection for focal epilepsies that are due to structural injury. And the other part would be medications that affect the networks more specifically. So it's medication.
So the surgical treatments in 20 years are not going to be dominant. It's going to be metabolic, genetic, and so forth. I mean, that makes sense, right?
Well, surgical would be, I think, devices.
I understand.
Maybe more.
Yeah.
More implants.
If you had certain networks and so forth, it could be implants, right?
Right.
Well, there's already, trials that show deep brain electrodes can influence epilepsy and suppress it in some cases. So maybe brain pacemakers in the future, rather than just chopping out a lobe.
Okay, right. Okay, I'll buy that.
And I think all of us would rather do less damage.
Correct.
Resective surgery is still the most efficacious treatment for refractory epilepsy, drug refractory epilepsy. The question is how to increase that with more refined surgical approaches.
Excellent. Thank you very much.
Pleasure.
Thank you very much.